So good morning, dear Chairman, dear colleagues. I would like to thank the organization for the opportunity to present our study in this session. And I am presenting our new AKI-Predict-score, which is a new model to predict acute kidney injury after liver transplantation. Acute kidney injury after liver transplantation is a common complication, and it is associated with impaired survival rate and an increased risk to chronic kidney disease. It has multiple risk factors. First, many patients already have an impaired kidney function before their liver transplant due to their liver disease with the hepatorenal syndrome or septic episodes, but also due to comorbidities like diabetes. Secondly, during the transplant, extensive blood loss, the use of vasopressor, but also the increased use of high-risk grafts is an important factor. And then the last hit is actually after the transplant with the nephrotoxic immunosuppression and post-operative complications like bleeding and infections. To come back to the graft quality, there are several graft-related factors that can impact on the kidneys, like the donor age, steatosis, the use of DCD grafts, but also the prolonged duration of cold and warm ischemia times. This all has a negative impact on the hepatic ischemia reperfusion injury, and the kidney is a known organ to suffer from this phenomenon due to the extensive release of pro-inflammatory cytokines and reactive oxygen species, which then further in severe hepatic ischemia reperfusion injury. So the aim of our study was to develop a new model to predict which patients are at risk for AKI after liver transplantation. And we aim to develop a practical score that first is comprehensive by combining graft, recipient, and surgical factors, that is simple with not too many factors and directly available after the transplant. So we used two study populations from the Queen Elizabeth Hospital in Birmingham, United Kingdom, and Erasmus Medical Centrum in Rotterdam, the Netherlands. We included all primary adult liver transplantation and excluded the retransplant, the super urgent transplant, because most patients already have acute kidney injury before. Of course, the combined liver kidney cases and those with pre-op dialysis. The definition of AKI we used were the KDIGO criteria, which are mostly used in recent literature, which is based on a rise in serum creatinine. We then have 3 stages, and we decided to look at or to predict those patients that will develop severe AKI. And this is because the stage 2 and 3, and this is because we have shown before in both the DBD and DCD cohort that those 2 stages actually have the most impact on the long term with impaired survival rates. We used, to develop this risk score, we used the Framingham risk scheme, which is known for the cardiovascular risk assessment. And it's based on a multivariate regression analysis. So these are the first results. Total population was 1,230 patients, and these are the baseline characteristics. You can see that the donor age is around 52, 53 in both cohorts. And also, almost to 1/3 of the patients received the DCD graft in both Rotterdam and Birmingham. Cold ischemia time was a bit longer in Birmingham. The age of the recipient was comparable in both centers. You can see that the MELD score, which is the biological MELD score of the actual lab values, is 16 in Rotterdam and a bit lower in Birmingham with 13 points. Preoperative serum creatinine were comparable. Then the transplant procedure, you can see that the warm ischemia time or the implantation time of the liver was 10 minutes longer in Birmingham, and this was because previously, or likely due that previously in Birmingham they did an additional flush just directly before a reperfusion. The peak AST level, which is a surrogate marker for the severity of ischemia reperfusion injury, was higher in Birmingham with 1,300. So then the incidence of acute kidney injury. As you can see, more than half of the patients developed any form of AKI, 56%, and severe AKI, the stage 2 and 3, was observed in 1/3 of the patients and more common in Birmingham. So I will shortly show you how we developed the score. We analyzed more than 20 parameters of the donor, recipient, and also surgical factors, and we identified these 5 factors with the multivariate analysis: the donor and recipient body mass index, the use of a DCD graft, the number of plasma transfusion during the transplant, and the duration of recipient warm ischemia time. Then we divided the continuous variables in categories. And then if we now look at the donor body mass index, you can see that we have the beta value, the regression coefficient, which is here minus 0.3. If you then look at the reference value or the midpoint of both categories, or like the median in this case, you can see that for the lower category it's 23, and for the higher category it's 28. If you take that difference, which is 5.4, you multiply that by the regression coefficient, you get this beta number, which is 3.1. If you then round that up to a whole number, you have your risk points for this parameter. And then in total for all the parameters together, this led to a total maximum point of 25. We then divided those 25 points into 3 risk groups: the low risk group with 0 to 10 points, the intermediate group up to 20 points, and the high risk group for more than 25 points. This is the ROC curve for the model, which has an area under the curve of 0.7. We then not only looked at the incidence of severe acute kidney injury, but also other outcomes. And you can see here that both the graft survival and patient survival, that the low risk, the green line, and the intermediate risk, the blue line, had comparable long-term survival rates, but those with a high risk, so more than 20 points, had a significantly impaired graft and patient survival. We also investigated the risk score in according to complications, and we therefore used the Comprehensive Complication Index that was developed by the Zurich team. And this is an assessment of the total surgical morbidity and a sum of all postoperative complications. And it has a scale from 0 to 100, where 100 represents death of the patient as a maximum score. You can see here that the Comprehensive Complication Index, or the CCI, increased significantly after 30 days with a low, intermediate, and high risk. And finally, we looked at the AKI-Predict-score and immunosuppression. And this is about the tacrolimus-based immunosuppression or delayed introduction of tacrolimus with on day 3 or 5, and then the patients had MMF from day 0 and basiliximab at day 0 and 4. And you can see that in the entire group, the incidence of severe AKI was 40% in those who had a tacrolimus-based regimen, and only 17% who had the nephroprotective regimen. And if then you look at those patients with a more increased risk, so the intermediate and the high-risk group, those who had a tacrolimus-based regimen, almost half of the patients, 45%, developed severe AKI, and significantly less patients, only 29%, developed AKI if they had a nephroprotective regimen. There are several points of discussion. Of course, the cohort size, we think it's a relatively large cohort with more than 1,000 patients. We would like to have more patients, but we cannot use like all the registry data because you need very granular data with all the creatinine levels and all the risk factors. So we had to use our own local databases, but that result is that we have less, almost no missing data. Of course, we would like to validate this score in other cohorts, and especially in cohorts with higher biological MELD score. But we think this score is useful to use as thresholds in decision making. So we suggest that if you have like an intermediate risk, so more than 10 points, you could consider a nephroprotective immunosuppression. And even in the high-risk patients, you could consider early dialysis. And this paper confirms that it's not about transplant patients, but they have investigated that in an overall population of critically ill patients on ITU, early initiation of renal replacement therapy can be protective and decrease the risk of mortality in those patients. So this is not the first score developed for AKI after liver transplantation, but it is the largest. These two scores are both from the Far East, from China, a DCD cohort, mainly DCD, and the living donor cohort from South Korea. They both have good prediction values, but we think that the main disadvantage of these two scores is that they included also the postoperative risk factors. And we actually, with the immunosuppression, we think that that is too late, because you actually want to have a score that is already there, and then you can decide what you're going to do postoperatively. So in conclusion, the AKI-Predict-score is a useful tool to predict development of acute kidney injury after liver transplantation. It's comprehensive by combining graft, recipient, and surgical factors. It's easy with only 5 parameters, and we think it has better timing because it's directly available after the transplant. So it can assist the doctors in decision-making for the immunosuppression strategy, to consider early dialysis, but also to anticipate for a difficult postoperative course, as we have shown with the long-term survival and also the complications. Thank you for your attention.
Nicely done. This paper will now be discussed by Marcos Perini from Australia.
First of all, I'd like to congratulate you for presenting the conjoint data from Birmingham and the Erasmus, and also to acknowledge that you have been very productive in the last 2 years in the liver transplant field. So I had a look at your CV, 15 papers, well done. You have shown that the risks of having AKI, they rely on the pre-op, intra-op, and post-operative factors. On the pre-operative risk factors, apart from BMI, I haven't been seeing anything in your data about diabetes and hepatorenal syndrome. So there are two big factors that we should take into account. So my first question, from a couple of them, have you considered diabetes in your risk factors? So we do know that in the British Journal of Anesthesia a few years ago, they published a risk score, not similar to yours, but involving this same cohort of patients, and diabetes was a prognostic factor. My second question is regarding operative factors. So you also published a few years ago that post-reperfusion syndrome is a risk factor for post-operative AKI from the Erasmus database. The odds ratio in your study previously was 2.3. That was confirmed by another couple of studies. Why, if you are joined the data from Erasmus and Birmingham, still post-reperfusion syndrome was not a significant risk factor? So if you can explain to me. My third question is related to the graft quality. So we do know that graft quality has a major influence on the AKI post-op, so fatty livers and even more DCD donors. So our own results from our center show that with an error under the curve of 0.87, we can predict more than 80% of renal failure in our patients, in DCD donors, I'm telling you. So why DCD donors in your risk score just have a score of 1? So if you look at your data, so your BMI of 25, almost all your recipients and your donors, the BMI were around 25, and still BMI is more important than DCD grafts. So if you can explain that to me, I would be delightful. My fourth and last question is related to the outcome. So I would say that from a predictive point of view, with a ROC curve in an area under the curve of 0.7 and positive predicted value of 62%, it's a bit of a stretch to suggest post-op early renal replacement therapy for these patients. Even more, in Switzerland, we are close to France, they just published 2 years ago from the AKI group, and they showed that early early dialysis actually doesn't play a role. I do know that you showed the JAMA paper, but the AKI published in the New England didn't show anything related to that. And I hope that my 4 questions covered a bit of it, and well done, great job.
Thank you.
So we would appreciate brevity in your response.
To answer your first question, yes, we analyzed diabetes and other comorbidities as well, and they were not significant factors in these 2 cohorts. To answer your second question, and I'll have to think a bit, about first the DCD. It's true that it only has 1 point in our score. This could be due to that DCDs, we give DCD grafts also to patients with a lower risk. So that might be that patients with higher risk receive more like the fatty grafts instead of the DCD grafts, and they then have a smaller risk to AKI, but it still is a significant factor. And to answer your question about about the post-reperfusion syndrome, it's true that we published that data from Rotterdam, what we have seen the last couple of years, I've seen it both in Rotterdam and Birmingham, that the anesthetists are really anticipating already to the post-reperfusion syndrome. The definition of the post-reperfusion syndrome is just a drop in blood pressure. And we see now that already the patients get a bit of noradrenaline before reperfusion, so you can actually not measure that anymore. So we think that it's also important that we actually maybe together we can develop a new definition of the post-reperfusion syndrome. So that's why we did not use it in this score. Can you help me a bit again?
I think we may have to leave it. We may have to leave it at that in the interest of time.
Okay.
So thank you very, very much.
All right. Thank you.